Thank you, Ms Hannett. And now we have Mr Wagner, who's that way.
Good afternoon, Professor. I want to ask you, sorry, I should say first that I act for clinically vulnerable families. I want to ask you first about the DFE guidance in July 2020 on schools reopening. I appreciate it's not your guidance, but one of the things the guidance said was that because shielding had ended, was about to end, this was a good justification for almost all children returning to school in September 2020, so a month later, including clinically vulnerable children and children in clinically vulnerable families. And my question is this: at the time that shielding was paused, did you know that or anticipate that it would be used in this way to justify previously shielded children or children in shielding families being mandated to attend school just a month later?
Well, I'm going to sort of repeat an answer I gave earlier, because I think that overlaps quite heavily with something which Counsel for the Inquiry asked me. But I think let's separate out two separate sets of things. The first set of things is the question, was the reason that we were advising children who'd been previously advised that they were clinically vulnerable or clinically extremely vulnerable to go to school, was that because we were pausing shielding? And the answer is not really. The principal reason was because we no longer thought that they needed to have shielding based on much more up-to-date information. So in contrast to adults, where we considered the risk was still there, but had gone a long way down because the amount of COVID was much lower in the summer. In the case of children, our view was the risk was not there for that reason, but more importantly, it was not there because there was no evidence they were at increased risk in the first place, or at least in any meaningful way compared to peers of the same age. The separate question, which I think I hopefully also addressed earlier, was the question about a child in a family where the adult is shielding. And here that is slightly more of a relevant consideration. In the period when the schools reopened, the level of COVID was extremely low. So the probability that the child, by going to school, would be introducing it to the vulnerable adult, and the vulnerable adult would therefore come to harm, was actually very low, just on purely statistical grounds. So to that extent, the shielding point was relevant there. But there was a wider point, which was, by this point, the harms of children not going into education were really clear. And there was a policy decision, which I think most people would consider is very reasonable, that we would prioritise the needs of the child for their lifelong learning, given the relatively small additional risk that this posed elsewhere.
Thank you. And clearly the risks went up and down through that period, and those different factors you've described will have gone up and down as well. And I just want to ask you, in that respect, about choice. And I think you said in your in Module 3 that the end of shielding wasn't a cliff edge, because people who were clinically vulnerable chose, perfectly reasonable, to continue what they'd previously done. So some people chose to do one thing and some people chose to do others. Now, would you accept that when it came to school attendance in September 2020, but also going into the autumn as cases started to rise, that it was important that those families that had a clinically vulnerable member of the family or a clinically vulnerable child could continue to choose to do what they had previously done or to shield as the risk factors started to change?
So I think that in a sense, and this is just a development of what I've just said in the last answer, in the case of the children, we no longer thought that they were clinically vulnerable, and that was our clear advice to them, based on data put together by the Royal College of Paediatrics and Child Health. So in contrast to the adults, who were still clinically vulnerable, but we thought the risk was low because there was not much COVID, in the case of the children, our view was they weren't clinically vulnerable in the first place, based on objective evidence. So that's the first clear point. There are a small number of people to whom that was an exception, but that was a very small subset of the number of people who we initially thought might be at increased risk, fortunately. I think on the question about mandation of schooling for children in a context where actuarially the risk is very low because the transmission rates were low at this point, the question about whether schooling should be compulsory or not strikes me as absolutely a question of political choice and societal choice rather than a clinical question. So in a sense I would defer it, but I would say that historically governments around the world have always tended to have a strong view that children should have education for their long-term benefit, and I'm sure it's on that basis that these decisions are taken by political leaders.
I'm out of time. I've got one more question.
All right, Mr. Overton.
Thank you very much. Just finally, and it's on a similar topic, who do you think should determine whether shielding or non-attendance at school for a clinically vulnerable child or a clinically vulnerable family is necessary? And I ask that in the context of the reports from CVF members, a lot of CVF members, that often when they, and particularly when the case rates were not low, that they were told during that autumn that and winter that their children had to attend or they'd be punitively dealt with.
Well, I think all of your questions are essentially the same question, so I will give a sort of same answer, which is the decision as to whether someone is or is not clinically vulnerable as an absolute, and the decision about whether this is a point in time which is a high-risk person for clinically vulnerable people are questions of, in a sense, epidemiological and clinical fact. So I think reasonably you would expect medical practitioners at an individual level and epidemiologists and public health people at a population level to be giving that advice to the public and therefore to individuals. The question as to whether the force of the law can be used in one situation or another is entirely one for essentially the proper authorities, and if the law is going to change for Parliament and political leaders, it's definitely not one for the medical profession. So our job is the first bit, to help define the group of people who are at risk and to make sure they understand that risk, and to make sure that the political leaders understand those risks when they make their decisions. The second choice is not for us.
Thank you.
Thank you, Mr.